So today I'm going to be talking about two cases for my case connection number 2. The first case is case number 3, and it states, a 5-year-old boy is brought to the pediatrician's office for an annual visit. The mother reports he has been a sickly infant and often appears drowsy. She also has concerns over his son's persistent thirst and frequent urination. Blood samples are taken for insulin measurements at time 0 and 1 hour after a glucose loading test. The results of this test are illustrated in the table below. There are 3 things I'm going to be answering, and that is, what is this information likely to suggest about the underlying biochemical basis for the patient's symptoms? What would you predict the patient's fasted blood glucose levels to be given his current condition? And to list 2 regulatory enzymes that are likely to be active in this individual's current condition. So seeing the data that is presented in the table, you can see how the patient's insulin levels do not rise very much from the baseline blood sample to when they retest an hour later after a glucose load is given. The control levels, which would be considered normal during the baseline blood sample, are seen to be higher than the patient's insulin level after a glucose load, so right away you can see that there is a problem going on in this 5-year-old boy. As stated in Chapter 19, insulin plays a central role in regulating blood glucose, so this is why these levels rise after the boy gets a glucose load and is tested an hour later. Based on the table, you can infer from Chapter 19 that there is a decreased secretion of insulin, which is caused by an impaired glucose tolerance. With this, it is easy to see that the child could have type 1 diabetes mellitus. The symptoms that the 5-year-old boy is demonstrating include appearing drowsy, persistent thirst, and frequent urination. When researching type 1 diabetes mellitus, Mayo Clinic lists these characteristics as the main symptoms of type 1 diabetes, along with the insulin levels being low, which causes little energy to be produced, causing the drowsiness. Chapter 14 talks about how in order to raise the insulin levels after 1 hour after a glucose load has been administered, insulin would need to be introduced so that the muscle and adipose tissue will be able to take up glucose from the bloodstream. Since the child might have type 1 diabetes mellitus, this would mean that the child is not able to synthesize and secrete insulin, which would later on lead to severe metabolic derangement, which is noted in Chapter 14. I think that the patient's fasted blood glucose levels would be above the normal range. I think this is because in Chapter 19, there is a graph which shows the glucose levels of a diabetic person versus the levels of a person without diabetes, both after being administered glucose. The diabetic person is always a lot higher even before receiving the glucose load. This is caused by the insulin levels being so low that the body reduces the glucose uptake. Due to the 5-year-old boy's current condition, there are many regulatory enzymes which are going to be currently active. Those enzymes include glucose 6-phosphatase as well as fructose 1,6-bisphosphatase. In this boy, insulin is very low, and in order to allow more insulin into the body and there be an increase, there needs to be an increase in glucose 6-phosphate as well. As stated in Chapter 14, the glucose 6-phosphate is hydrolyzed by glucose 6-phosphatase, which then causes glucose to be released in the bloodstream and be used by the body. On the other hand, in Chapter 18, glucose 6-phosphatase catalyzes hydrolysis of glucose 6-phosphate, which in turn yields the glucose that is being exported, which would lead to an increase in blood glucose concentration. This is done only in the liver and would in turn lower the insulin levels, such as that seen in the 5-year-old boy. The other enzyme which is active is fructose 1,6-bisphosphatase. As noted in Chapter 19, without this enzyme, the body is not capable of synthesizing glucose, which would in turn have an effect on the insulin intake. The next case I will be talking about is case number 4, and that is a previously healthy 2-month-old female presents with jittery spells several hours after breastfeeding. Her mother reports she has not given the baby anything to eat other than breast milk since birth. The baby has only recently been sleeping for more than 2 hours between feedings, and that's when the mother reports these symptoms started. Laboratory results are consistent with hypoglycemia, which means having low blood glucose, but are otherwise unremarkable. Epinephrine is administered, and there is no increase in blood glucose, but there is an increase in blood lactate. Physical exam reveals a liver edge 4 centimeters below the right costal margin. Percussion of the right chest and abdomen confirms hepatomegaly. Blood glucose levels increase after breastfeeding, but she cannot maintain blood glucose levels within a normal range during fasting. Based on the information above, which of the following is most likely the diagnosis of this patient? A. Hereditary fructose intolerance. B. Galactosemia. C. Glycogen storage disease, or D. Glucose 6-phosphate dehydrogenase deficiency. When reading about this case, I first looked into all the symptoms that the 2-month-old female was expecting. The symptoms that stood out to me included the blood work that was consistent with hypoglycemia and how epinephrine was incorporated into the treatment. This meant since there were signs of hypoglycemia, there was low blood glucose levels found in the blood as stated in the problem. The baby had been sleeping for more than 2 hours, so had not eaten, and with being so young, the baby could now be in a fasting state. This would affect the liver because the glycogen that is secreted will need to be able to maintain the blood glucose, which clearly is not being done here. Epinephrine is a hormone which is responsive in these types of situations, and since the baby has low blood glucose, epinephrine helps by acting on the liver and releasing glucose into the bloodstream as mentioned in Chapter 19. The case also mentioned how after an exam, it was confirmed that the baby had an enlarged liver. According to the University of Chicago Pediatric Clerkship, hepatomegaly is defined as a liver edge 3.5 centimeters below the right costal margin in newborns, and in this case, the liver was 4 centimeters. It is also mentioned that this is caused by buildups in the liver, which can lead to other issues such as glycogen storage disease and disorders of lipid storage. Since this can possibly lead to glycogen storage diseases, option C now seems as if it can be possible diagnosis. Now looking at the options, I think that option A is not the answer. According to Chapter 20, hereditary fructose intolerance is characterized by hypoglycemia as well as vomiting after ingesting fructose or sucrose, and this could be in the mother's milk that the baby is eating. Since the baby is not experiencing vomiting as a symptom, hereditary fructose intolerance is most likely not the correct diagnosis. Option B is galactosemia, and according to Chapter 20, liver failure is a result of this, which going back to the hepatomegaly, the liver could go into failure. According to Chapter 20, galactosemia is caused by an inability to metabolize galactose, and according to the U.S. National Library of Medicine, galactose is present in many baby formulas. Because the baby was only drinking the mother's breast milk, this would mean that there would be no signs of galactosemia. Some symptoms that may arise in infants include being lethargic and experiencing feeding difficulties, which the baby was not showing. Lastly, option D, glucose 6-phosphate dehydrogenase deficiency, is not the most likely diagnosis of the patient. That is because normally in the liver, glucose 6-phosphatase catalyzes hydrolysis of glucose 6-phosphate, which yields the glucose that is exported, which in turn leads to an increase in the blood glucose concentration as stated in Chapter 18. The symptoms the baby was demonstrating was the opposite of this and was shown having low blood glucose concentration. Defects of glucose 6-phosphate transporter could even cause types of glycogen storage diseases. With all of this known, option C would then be the best answer out of all the other ones. According to Chapter 18, glycogen storage diseases are a group of inherited disorders characterized by deficient mobilization of glycogen or deposition of normal forms of glycogen, leading to liver damage and muscle weakness. It is also noted that there is a failure to mobilize glycogen, which is the main symptoms of glycogen storage diseases. This is seen in the baby when blood glucose levels are low and remain low even after the epinephrine is administered.